All right, guys. This is my video to help you guys understand the different rhythms of the heart based on their conduction, where they stem from, and how they flow through the heart. Bear with me, I've never taught, so if I mess up some wording, just look past it. All right, so let's start with the electrical conduction of the heart. So in a normal patient, your electrical signal starts in the SA node. Once it generates it from the SA node, it flows down to get to the AV node, which would typically be right here. And then it'll flow through your bundle branches and your Purkinje fibers, right? So it flows down this stream, splits in two at the bundle of His, and then it'll go down both sides of these bundle branches throughout the Purkinje fibers. Essentially what it's doing here is it is dispersing the electrical signal evenly throughout your ventricles so it can contract all at once. So yeah, this is just a written form of that. It starts at your SA node, goes through your AV node to your bundle of His, down your left and right ventricles, and then your Purkinje fibers. So when you do an ECG or an EKG, they essentially mean the same thing on a patient. It'll show up in or on a pink piece of paper like this, essentially. And what that's doing is giving you the different views of the heart, so that if there's a problem on the left ventricle or the left bundle branch compared to the right bundle branch, they can pinpoint it better and get intervention where it's necessary. All right, so this is just an image of how the lead placement gives you the different views of the heart. I added this photo over here. Obviously, your leads aren't going to be placed on your wrists, but that's the concept of it. When you do a 5 lead, which is what they do in the hospitals, unless they need a more accurate representation, then they'll do a 12 lead, which is typically what they do upon admission, or when they really need to analyze a rhythm that they've seen that has gone across the 5 lead viewing, right? So the different leads will give you different side views, and this is just it in perspective to the body. So the RA is the right arm, the LA is the left arm, and the LL is the left lower. When you put on a 5 lead, you'll have the RA, RL, RA, oh, I'm sorry. Oh. You'll have, come on. Okay, the LA, LL, and then the V lead is in the middle. So that just means right arm, right lower, left arm, left lower, and then this is just the middle lead to be able to give you all the views of the heart. So I added some videos some pictures onto this slide, just so that you can see what they put on the patient in regards to what they are. So the electrode placement, those are your leads, and these are the stickies they'd be putting on your chest for those leads. And then these are the wires that they connect to those. And that 5 placement system that I mentioned on the last slide, they're color coded. So you could identify them by, the name right arm or the color, which I don't think that's in the book, so I'm not going to get too deep into that. I just wanted you guys to see a visual of the electrode placement that is talked about on this slide. And poor lead placement that it says right here, it could lead to artifact, which is essentially just extra scribbles or not being able to see a clear rhythm on those leads. And I mean, yeah, that can be due to hairy chests, or even people brushing their teeth can give you terrible rhythm patterns. But that's why there's people like me who identify real from fake for those rhythms. Okay, so the electrical pathway of the heart. So you have your P wave first, which is the green one, and then your PR segment is your atrial depolarization and repolarization, and that creates your PR interval. Then you have your QRS, which is your ventricular depolarization, and then your ST segment, which is that back blue bump, that is just your ventricles repolarizing. Your P wave is going to be a smaller bump because it stems in one spot, which is that SA node. Your T wave is going to be, your QRS is going to be bigger and wider because it's all of this working together to send that electrical signal out to contract those ventricles. And then your T wave is just the ventricles repolarizing. It's like it's a standalone thing. All right. So this is where she was talking about in class, where the little boxes, one of the extremely small boxes are 0.04 seconds, 5 boxes is 0.2 seconds, and then 5 boxes is 1 second. So she did say that typically when you're given a strip from, just to analyze the ones that are sent to the chart, they're going to be 6 seconds long, which will help you identify the rate of the rhythm because, like she said, if you're given a 6 second strip and you've got 60 seconds in a minute, you would just times it by 10 to give you the rate, the beats per minute. So yeah, this is just the longer way to do that. I personally will not be counting 300 large boxes. So that's just a quick, easier way to be able to identify the rate of the patient. Okay, so for your ECG interpretations, like we talked about earlier, you have your P wave, your QRS, and your T wave. I don't think that the P wave, many doctors don't look at the P wave on its own. What they're looking at is your PR interval, which is on the next slide. So we'll talk more about that one, but for this one, your QRS, it should be less than 0.12 seconds in duration. Anything bigger than that puts you more at risk for, well, it is a bundle branch. And so essentially what that means is that your heart is taking longer to contract those ventricles, and it's just moving slower, which isn't safe. Obviously, that can lead to more things. Your T wave is present. That's important because obviously if you have things like ST elevation or depression, those can be risk for myocardial infarctions. That's why they call it a STEMI, because it's ST elevated myocardial infarctions. So it is important to watch the T wave. And a U wave, I mean, I don't see them very often. They're not something to really worry about. If you do see one, it's just an extra little wave on your strip. All right, like I said on the last one, your PR interval is what's important for your P wave. You want it to be 0.20 or less. Anything greater than 0.2 is considered a first degree, which we'll go more into that later. That's just the electrical signal taking longer to travel down past your bundle of His into your ventricles. And then you have your ST segment and your QT segment. So here's just another physical or visual representation of one. You've got your PR interval, which is where the P wave starts, which is where it disconnects from the baseline. And then where your PR interval ends is right before that QRS, or where that Q starts for your QRS. Your QRS is from, let me see if I can get a different color. Nope, I'm not going to stress about it. Okay, so your QRS is where the Q starts and then where your S is. So QRS, that's your ventricles depolarizing. And then this is your T wave right here. Your T wave is your ventricles repolarizing. Okay, so there's two important factors into identifying a rhythm. I talked about this in class, which essentially the first thing you're going to want to do is identify if your patient has a P wave. I don't like these two. I'm going to move these down. So the first thing you're going to want to do is identify if your patient has a P wave, because that determines what kind of rhythm you have, if you have a dysrhythmia, or if you have a variation of a block. Okay, so once you identify if it has a P wave, then you're going to see if it has a singular QRS and then the T wave, and if your R to R intervals are equal, to be able to get the rate by counting how many R to R or how many QRSs you have in 6 seconds. Okay? And this is what we were doing earlier, this side. This is us identifying if the P wave is shorter than 0.2, checking your R to R intervals, and then, the P to P wave intervals are important for when it comes to a block. So let's move on and start to get into the rhythms. All right. So for a normal sinus rhythm, right, what are we going to do first? We're going to identify the P wave. So if we're looking at this rhythm over here on the left, you can see P wave, P wave, P wave all the way across, right? All right. Then you're going to look to see the R to R intervals. These are your QRSs. Your R to R intervals are the peak point of your QRS to the next peak point of your next QRS. And making sure those map out, which it looks like they do. If you had calipers, you'd be able to see, don't pay attention to this one, but you could see that they all map out. Okay? So this is normal sinus rhythm. Every P wave has its own QRS and a T wave. Then it's at its baseline, and then your next P wave, QRS, T wave starts. Okay. Sinus Brady is the same thing, just a slower rate. You're going to first identify your P waves all the way across. You've got your QRSs. Your R to R intervals are the peak to the peak. And then this is a 6-second strip. So you're going to count how many QRSs are in here, times it by 10. Your heart rate is roughly 40. Okay? All right, now we've got sinus tach. It's the same thing, just a fast rate. All right? So you've got your P waves, P wave, P wave, all the way across. You've got your QRSs all the way across. Your R to R intervals are pretty consistent. So this is sinus tach. The difference between sinus Brady, normal sinus, and sinus tach is just rate. So sinus Brady is anything lower than 60. Anything lower is Brady. 60 to 100 is normal, and anything higher is tachycardia. Okay? And that's how you tell the difference between sinus brady, normal sinus, and sinus tach. All right, sinus arrhythmia, it's really not something to worry about. You can clearly see in this strip, you've got a P wave for every singular QRS. The heart rate changes with your respiration. So essentially what that means is when you inhale, your heart rate might go up a bit, and when you exhale, your heart rate goes down a little bit. This is what the professor said. The professor said this is very common in athletes, probably because they have a healthy heart. So I don't want to speak on anything I don't know, so I'm just going to stop there. But I know that it has to do with your respirations. So that's the only variation that causes, or that's the only variation that would affect your sinus rhythm, just how you breathe. Okay, now we're getting to the arrhythmias. So arrhythmias are the disorders of formations and conductions. Essentially what that means is your electrical conduction isn't necessarily stemming from where it's supposed to be stemming from, which is your SA node. And so, of course, that can affect your rate, your rhythm. Yeah, I'm not going to speak on anything else in there. All right, so the different arrhythmias you can have. So for your atrium, you can have atrial flutter, atrial fib, premature atrial conduction, and SVT. And then for your ventricles, you can have premature ventricular contractions, or complexes, I guess, but they're called contractions. Ventricular tachycardia, ventricular fib, and then asystole is essentially what that last one is. So I pulled this photo because it shows that, yes, your SA node is where that impulse should stem from. But essentially what is happening is you have all these different baby foci points, which are electrical points in your heart, and you have them in your ventricles too. And these electrical points are where either some impulses come out of in order to send it to your SA node, or in your ventricles, it helps to contract your heart all at one time. And so it pulls it and it helps conduct it through those systems. All right. So let's look at AFib and A-flutter. So if you're looking at AFib, you can see that there is no distinct P wave in your rhythm. You've kind of got these just little squiggly lines. Excuse me. Okay, so you've got no distinct P wave and these little squiggly lines in between. So essentially what is happening is all these foci points in your atrium are firing rapidly to send a signal down through your AV node to initiate your QRS complex. So they're all just collectively firing to send it down. This means that that signal doesn't stem from just one singular point, which means that your atrium is just essentially quivering to get that signal down to produce that complex, which creates the squigglies. The difference between AFib and A-flutter is that with AFib, it's all of these little foci points that are irritated trying to send it down. With A-flutter, it's a singular foci point continuously sending a signal repeatedly, and it's just rapidly firing, sending that signal down. So that's what causes it to be more consistent in your heart rate, or more like, as Quaid said, mountain points. It's because by stemming it from one, it has a stronger signal to send down, which gives you higher peaks, where when it's from atrial fib, because they're all firing rapidly, there's smaller electrical impulses in order to send it down. All right, so this is just a little tester to see if you can identify the two. What do we think the top one is? Atrial fib, right? Because as you can see here, your heart rate is more irregular and you've got more squigglies than more mountain peaks. And so what do we think that the second one is? Atrial flutter. I think I forgot to mention, guys, that with atrial flutter, your R to R intervals will be more consistent across, because it's coming from a singular point. All right. So now we're going to go into the atrial arrhythmias. So with a premature atrial contraction, which is a PAC, essentially what's happening is your primary beats are coming from your SA node, but every once in a while you might have an irritated foci point, which is one of these, and so it'll shoot an extra signal down, which will make your QRS or your P wave contract sooner than normal. So the only thing that changes is the distance from that one QRS to its previous QRS. The signal is still traveled down the SA node. So when a PAC happens, it is affecting the P wave, bringing it forward because it's a premature contraction of the heart, which then shortens that distance before the next one. Okay, I put SVT next because they relate to each other. Premature atrial contractions and SVT relate to each other. So how I just explained that a singular PAC is a foci point irritated, sending that electrical signal down that node. SVT is essentially a foci point extremely irritated and continuously sending them. So that P wave that is there is hidden in the previous QT wave because it's irritated, so it's beating faster. SVT stems from above the ventricles. That is why it only changes the distance from one QRS to the next and not the actual shape of the QRS, because it's affecting your atrium and not your ventricle shape. So if it stems from the ventricles, it would mess with your QRS. Okay, so for your ventricular arrhythmias, we're going to start with a PVC. So PVC is a foci point in your ventricles irritated. So as the signal transfers down, you might have just an irritated foci point and it'll send out an electrical signal, which causes it to contract early. So when this happens, it typically is a bigger QRS complex. And then directly after, you're going to have this thing called a compensatory pause. All All right, so with ventricular tachycardia, it's essentially the same thing as a PVC, but a bunch of them back to back. So essentially what's happening is there is a foci point within your ventricles that is irritated, and so it's continuously sending that signal not in its normal pattern and creating that wide complex because it's not dispersing it how it's supposed to be dispersing it throughout the entire ventricle. It's getting caught on that foci point and sending its electrical signal out too soon. So with V-tach, you're going to have those wide complexes through each one and almost like a hump in between. That's it. You won't have any atrial activity because this activity is coming from your ventricles. So in this case, your ventricles don't have enough time to repolarize fully or relax fully. So your QRSs are wider because it's not going to be a full beat, a full contraction. Therefore, your QRSs are typically wider in this one. All right, with VFib, it's the same concept. You've got your foci points in your ventricles. This is all of them irritated and just sending out electrical signals. At this point, no signal is coming from your SA node. It's all the signal is stemming from your ventricles, just trying to hold on to that last bit before your heart. Your heart's essentially starting to fail here. So it's just a bunch of those foci points in your ventricles irritated, trying to grab any signal that it can in order to contract your heart. Okay, in asystole, there is no electrical signal, so it is a flat line because none of the electrical signals are being sent out anymore. At this point, your SA node has failed, your AV node has failed, and your ventricle stimulations have failed. So it's just a flat line. Okay, now let's look at the heart blocks. So you've got 3 levels of heart blocks, but your second degree has 2 types. So in your first degree, what you're looking for is a PR interval that is greater than 0.2. Anything greater than 0.2 is considered a first degree, and essentially what's happening is your P wave is firing, but the signal isn't reaching past the next part, which is your AV node, or it's taking longer to, so then your QRS is delayed in firing. So just remember, with a PR interval, it's greater than 0.2, and every P wave still has a QRS. So it's 1 for 1 here. That's your ratio. Okay, so with a second degree AV block type 1, your PR intervals get longer with each beat until one is unaccompanied by a QRS. So essentially what that means is your first length is short, your second length, your PR interval is longer, your third is even longer, and then this one, there's no QRS here. Okay? So the phrase that goes along with this is longer, longer, longer drop. Now you have a winky block. And like I said, essentially what that means is your PR intervals slowly get longer and longer until one beat within that rhythm has 2 P waves. Your next block is a second degree type 2 AV block. So you will most likely see this in a more consistent manner, which is why I added this second one. And essentially what that is they also call it a Mobitz 2. And essentially what that means is there are 2 P waves for every QRS, okay? In order for this to be a second degree type 2 block, your P waves have to be in the same spot in regards to your QRS for each beat. So even here in this top one, you can see that if you mapped it out, like if you put a QRS right here, which is where it would typically be, you could essentially say that your R to R's map out, right? So I like this one better at the bottom because you can more clearly see that you've got 1, 2 P wave, the same distance from that QRS for each one, right? So that is the definers for a second degree type 2. In your third degree AV block, right, we're identifying that there are P waves there, but there's too many P waves per QRS. What's happening here is your SA node is firing, but it's firing on its own, and your QRS is firing on its own. Like the professor said, this is a scenario where you would want them to get a pacer, because it's essentially, if your QRSs are firing on its own, it means it's not really responding to the SA node, which is a danger, because that also means that they could just stop firing altogether. If they're not responding to its natural stimulant, then that's a danger. So the pattern here is that your P waves march out all the way across. If you measure your P interval to your next P interval, those would be consistent. And then your QRS intervals, so your R to R intervals, would map out, but there's no correlation together. Typically, your atrial rate, which is your SA node, right? Because your atrial rate is the electrical conduction that comes from your atrium, which is your SA node, will be faster than your ventricular rate. So your ventricle rate would be slower, and your ventricle rate is what makes up your heart rate. So your heart rate would typically be slower, right? So you'll see a lot of patients in the 30s, 40s in this rhythm. But just remember for this one, your P waves match up, your QRSs match up, but they do not match up together. And that's it. Thanks, guys. Hope this helps.